Good evening, everyone. Welcome to today's session of the East Africa Journal of Neurological Sciences Journal Club Bootcamp. My name is JOKAP, and I'll be your moderator for the third bootcamp session, representing the XYZZ Medical Research Team. A brief introduction on who we are. The East Africa Journal of Neurological Sciences Journal Club is a collaborative effort initiated by the EAJNS with the Journal of the Kenya Association of Physicians, that's JOKAP, the Journal of Obstetrics and Gynecology of Eastern and Central Africa, JOKAP of Africa. This is in partnership with XYZZ Med, SCORI, which is the Studying Committee of Research Education, the University of Nairobi Research Club, Kenyatta University Medical Research Club, and the Student Surgical Forum. This bootcamp aims to build scientific critical appraisal skills, increase engagement with local journals, and encourage early career researchers and medical students to participate more actively in publishing and peer review. Today's session will run for approximately 1 hour and is structured as follows. A 10-minute presentation by one of our partner organizations. Today we have the University of Nairobi Research Club, who will present a summary of the selected paper. A 20-minute open discussion and appraisal by you, the audience. And finally, closing remarks and insights from our guest editor, Dr. Sud Mohammed. I'll briefly read his biodata. He is a consultant physician nephrologist. He is the head of the Department of Nephrology at Coast General Teaching and Referral Hospital. He is a member of the Royal College of Physicians in the UK. He is also a member of the International Society of Nephrology. He is an editor in the JOKAP journal. He is a teaching faculty member in East Central Southern Africa College of Physicians and a chief examiner in the same. He also has several publications, both international and local. We are honored to have him with us today. So feel free to share your thoughts, questions, your critiques respectfully. This is a supportive learning environment for participants at all levels. And with that, it is my pleasure to invite Mr. Reinhard Kipkoech to present today's paper, which is titled Spectrum and Patterns of EEG Abnormalities in a Peripheral Outpatient Center in Kenya. Welcome, Reinhard.
I hope you can clearly see my screen as well as hear me clearly. So welcome to today's session, the third session on the critical appraisal bootcamp. And today we're going to be looking at a prevalence study. And our study is going to be the spectrum and the pattern of EEG abnormalities in a peripheral outpatient center in Kenya. And my name is Reinhard Kipkoech. Those are my achievements so far. And before we begin, I think it's imperative that we give a quick introduction of the University of Nairobi Research Club. Who are we and what we do? Currently, I'm the sitting vice chairperson. And what we do generally is that we take in cohorts at the beginning or twice a year for both semesters. I think we are continuing with our first cohort as we speak. We invite speakers to speak to them who are experienced or advanced in matters of research. We also hold critical appraisal sessions similar to this. And as we proceed into the academic year or into the semester, we now begin to work on the individual studies of a particular cohort members. So this year we are privileged to be part of the journal club to participate. And I think you can proceed or you can begin looking at this particular paper that we had for today. And like I've said, the title is going to be the spectrum and patterns of EG abnormalities in a peripheral outpatient center in Kenya. And those are the authors, Paul Budikara, Winnie Saumumweni, and Samuel Thuranira Mwenda. And also we have the address for the corresponding author, that is Dr. Paul Budikara. So should you have any questions, any clarifications you need to seek, I think you have the email there, you can reach out to him. So a brief introduction on the same. The electroencephalogram is an invasive test that is used to record the brain's electrical activity, and clinically it is used to evaluate seizures, encephalopathies, and several other neurological conditions. And of all patients that are going to undergo EEG and EEG test, are going to find that 50 to 60% of the abnormal recordings are going to be epileptic. And for now, we're going to have about 1 to 5% again of healthy individuals showing epileptiform discharges. So as we proceed to talk about this paper, you can already see that there is, or we need to be aware that. So when you talk about epilepsy, it is globally prevalent, about 50 million cases found globally. And when you look at now context, when you contextualize this particular case to now Kenya or low and middle income countries, you're going to have about 12.7 per 1,000 individuals having epilepsy. Then now in Africa, you're going to have 7 to 14.8 per 1,000 again having convulsive epilepsy episodes. Basically, again, you're going to have either convulsive epilepsy and non-convulsive epilepsy, which is self-definitive, non-convulsive, and convulsive. Now, this study was based on the fact that we have limited literature on, number one, the indications for the use of an electroencephalogram clinically, and number two, the limited literature on abnormalities that clinicians see whenever they take EEGs of patients. So the methodology, this study was a retrospective observational and non-interventional study, and lasted for 2 years and 7 months, from 1st June 2021 to 31st December 2023. And it was done in an outpatient clinic offering EEG services in Meru, Kenya. So data was collected in 2 ways. Number one, through an EEG, where now they were recorded for about 30 minutes in both awake and sleep states. And number two, under photic stimulation to assess the response of the brain to light, and now under hyperventilation. And of course, these two scenarios were also applied only on indicated cases where it was not contraindicated. The recordings were taken by a trained neurophysiologist and then interpreted by a trained physician or a neuroscientist for that case. Number two, we had the participants filling a structured questionnaire where they study, or the authors collected data on the demographics, the clinical and the variables of the electroencephalogram. Analysis was done by SPSS version 26. And then now the results that are found in this study. Now, out of a sample size of about 145 patients, we had 53.9% being male, and the mean age was 21.84 years. And of these 145 patients, over half of them were already taking anti-seizure medications. And the main reasons for these patients being referred for an EEG, number one was due to just to confirm the seizures. Number two, to assess the response to treatment as they underwent the particular treatment. Number two or number three, we had the diagnosis of these patients before they underwent the EEG test. We had 66.5% having epilepsy, 27.9% having encephalopathy, and 5.6% having or being psychotic. And then now abnormalities, we had out of the 440 patients, again 68.3% had EEG abnormalities. Remember that while the particular authors were setting up this study, one of the objectives was try to assess the spectrum of the abnormalities in the electroencephalogram of this particular patient. So for this, we had 63% of them having these particular abnormalities, and these abnormalities included generalized seizures, focal seizures, and the rest were normal. And of course, under the normal patients presented with the normal patients in the EEG presented with headache, altered behavior, and loss of consciousness. Then the most common abnormality was slow wave activity, in addition to the likes of spike wave activity and so on. And now the generalized epilepsy was most frequented in the age gap of 10 to 19 years. So, diagrammatically, this was the data, or these are the results that found in this study. Now, of all the patients, we have 55.73 having anticonvulsant or undertaking anticonvulsant therapy. 42%, about 42% having no medication, and while for the remaining 3%, there were no, or it was unknown. Then the complaints that brought them, or the complaints that caused these particular patients to be referred for an EEG, or seizure, forming 35% of these patients, unconsciousness 33%, altered behavior 13%, head 7%, and other reasons or 12 or contributed 12% of the participants. The distribution age-wise of these particular abnormalities, as you can see, the highest proportion was in the age gap of 10 to 19 years. Then we had under 10 years, and so on and so forth. Now, the diagnosis among these particular study subjects, the highest was generalized epilepsy, 42.7%. Of course, then the normal patients were 31.2% of the participants, and 19.3% of the participants had focal epilepsy, and 6.7% for encephalopathic. So the discussion, the higher prevalence in males and of course individuals under 20 years is a good reflection of now the prevalence of epilepsy in the Kenyan population. And of course, the leading referral reason was suspected epilepsy, and this is in agreement with previous studies that are cited in the paper. And like we said, 68.3% had EEG abnormalities. Again, this is similar to African or studies in the other African, rest of the African population, and the Asian population. The most common abnormalities were the slow waves, the generalized seizure patterns, and once again, this was also consistent with the regional trends. There was a high proportion again of children and adolescents in this particular study population, and this is indeed a reflection of now the proportion of epileptic patients or patients with abnormalities in the EEG in the Kenyan population. And it's also important to note that there was an agreement between the clinician's diagnosis and the EEG findings, in as much as there was no significant difference or no significant association between these two. And this goes on to confirm or to now underscore the value of EEG in confirming the seizures and screening for this particular brain disorders. So this is in support of the use or the need for the continued use of EEGs in this rural setting. This case. Then, as I conclude, it is important to note the role of the EEG in supporting clinical decision making for these particular patients with suspected disorders. And of course, due to the limited sensitivity of the electroencephalogram, it provides insight to the value of the EEG in confirming epilepsy, but not in exclusion, because you may find that the EEG may, due to the limited sensitivity, going to find that an EEG may not be enough to exclude a diagnosis of a seizure. So therefore, the accurate diagnosis of a seizure, you're going to require an EEG, of course, but this is going to be in addition and not a substitute of clinical evaluation. So the point of this particular paper or this particular study was to provide or to give the relevance of this electroencephalogram in addition to whatever is done currently in the management and the evaluation of seizures. And should there be ambiguous or normal EEG findings, like I said, it has a limited sensitivity. It is now recommended that you now have additional testing just to confirm these particular findings on the electroencephalogram. And therefore now, as we finish, the electroencephalogram is supposed to enhance diagnostic accuracy and of course ensure more effective management patient with these particular disorders such as seizures. And I think that brings me to the end of the presentation. And up to there, I believe you have a brief overview or an idea of what was going on in this particular study.
Thank you so much, Reinhard, for that concise summary of the paper. I trust we've all gained different insights from it. Now we move on to the next session. The floor is now open for the open discussion, where we'll have Mr. Felix Joroge take us through each section. You are all welcomed to share your thoughts and comments on the paper, either by raising your hand and you'll be unmuted, or through the chat box. So, karibu Felix.
Thank you so much, Joy, and thank you, Reinhard, as well, for the summary of the paper. And so just like last week, this is the main part of the discussion, and we highly encourage you to participate actively. So I hope and trust that each one of us was able to to review the paper and synthesize it and come up with your own thoughts and interpretations on the various sections of the paper as guided by the template that we shared with you for appraisal, as well as your own understanding and comprehension. So we'll just get straight into it. And as always, just we encourage you to be very active and mute. Lift your hand. So you lift your hand up and Joy will unmute you. And if you're not comfortable, you can also just use the chat box. We'll try and read as many of the comments and input that you give via the chat box. So we'll start. This was a prevalence study, and prevalence studies are meant to give the proportion of a population affected by a condition. They're very common studies, and that's why we chose them for this session. So we'll get started, and I encourage you to unmute. So we'll start with the title and authorship. So from your reading and understanding of the paper, do you think the title is reflective of what the paper is about? And does it identify the disease, the population, the setting? And when it comes to the authorship and affiliations, do you think they're transparent and appropriate for this study? So the floor is open. Please feel free to unmute and give your feedback as we start the critical appraisal. Anyone who'd like to open the floor for us tonight?
Yeah, hi. So the title identifies the disease or condition as, from what I understood, the spectrum and patterns of EEG abnormalities. The setting is referred to as Peripheral Outpatient Center in Kenya, and the country is named, but the specific area isn't included. The population is implicitly referred to as patients who visited the outpatient center, but from what I saw, there were no specific demographics like clinical status, and the study type, which is retrospective, is not defined in the title. About the institutional affiliations, the transparency is good because the affiliations are clearly listed, and also the authors have a strong academic basis, Kenya Methodist University, and also a clinical basis to be performing the study in that region.
Thank you so much, Nsolubi, for the courage and also for getting us started. Thank you so much. Anyone with additional thoughts? Maybe Joy could read the chat box for us.
Okay, yes. So from Zipporah Wahu, she says the geographical context is quite misleading since a peripheral outpatient center in Kenya is too general, since it could be anywhere in the entire country. Additionally, the study design was not highlighted. We have another response from Sumeya. She says the title identifies the setting, but does not mention the population, the disease, and the study type. She also says that the institutional affiliations are transparent and appropriate.
Thank you, Joy, and excellent. And also thank you all for your input. And just as we did last time, how would we rewrite the title if we were to improve it, and factor in all these things that we feel are missing from the title? Anyone would like to give it a go? Preferably, if you're able to unmute, please go ahead. But you can also use the chat box if you're not able to, but we encourage you to unmute. How would you rewrite the title, or maybe how would you improve on it?
Hi.
Hi,
I'd
Liz.
like to go. So I think I will rewrite it as spectrum and patterns of EEG abnormalities in a peripheral outpatient center in Meru, Kenya, and then colon, and then write the study design.
Which is, you can call it a prevalence study, because I think that was the main thing they were looking at. So yeah, so thank you so much for your input, and thank you all for your input on this section of the paper. So we'll move on to the next part. Unless anyone has additional thoughts, you can just feel free to stop me. So we'll move on to the abstract. So you're welcome to give your feedback on the abstract. Was it a good, concise summary, and a good snapshot of what the paper is actually about? And does it have all the key subsections that we mentioned should be part of an abstract? And are each of these subsections appropriately done? So the floor is open. Please share your feedback on this section and your thoughts as well.
Yeah, I can share some feedback. So the abstract was generally pretty good. It was well structured. It had the key subsections that they even highlighted them, so it was pretty good. The background, it gave a good overview of why the prevalence of whatever they're studying is important, and it identified the underutilization of EEG, despite like the high prevalence of seizures in the continent and in Kenya. Then the objectives were clear and they were measurable. And then the method section, it clearly included how the data was collected and the analysis methods, and as well, they also included the time frame, but it did not clearly identify the study population and the sampling technique used. I guess the study population can be implied to be the patients that were going in, like into the outpatient center, and they're from Meru, but it wasn't clearly identified. Then the results didn't have, it noted the prevalence estimates, but there were no confidence intervals included. And the inclusion was good, was able to outline the main findings and implications. And then the keyword section, it did have keywords, but I guess those were chosen by the authors. It didn't have the preferred mesh terms. Like I went to PubMed and I like typed in the keywords that were there, and nothing popped up, but they did have the section, which was also good. So yeah, that's what I have.
Yeah, thanks a lot, Clarence, for that comprehensive feedback on the abstract. So maybe Joy could let me know if there are any additional thoughts on the chat box.
Yes, there are a few responses. I'll start with Christopher, who says a concise summary. However, the methods section does not identify the sampling method. Zipporah says the abstract has clearly highlighted the background, objectives, methods, results, and result subsections. However, there is a difference in the IBM SPSS version here and in the method section, or one says 27 and 26. The confidence intervals were omitted also. Irene says the abstract summarizes all study components clearly and accurately, and all the key sections are well brought out. The study design, timeframe, and statistical metrics were clearly reported. The keywords section, however, does not include the regional context.
Thank you. Thank you all for the excellent feedback. And I hope, I think we're all learning from each other. And you can probably see where maybe places, everything, where things were, maybe it was done really well, and other places that could maybe be improved slightly. I think we will delve into some of these areas a bit more in the coming sections, especially the methodology, just to assess, because as we mentioned last time, the methodology is the whole study. So it's the one we really try to audit with the keenest eye. And I think the person who caught that inconsistency in terms of the version of SPSS used, that's a very commendable job. Means you had a hawk eye and you paid attention to every single detail. And yeah, so thank you for the feedback on the abstract. But I believe generally this abstract was good and was a good summary of what the paper was about, in that if you also read the abstract, because majority of the time people, when just view the abstract and review it to decide whether or not this is a paper they're looking for, or just to get to have a very quick idea of what the paper is all about. So it always needs to be really well done, and that it will capture all the main things that the study is about. So I think that's satisfactory for the abstract. So as we progress, you just keep self-appraising as well. Just appraise your appraisal. I know a number of you have already submitted your reports. So just see the things that you missed. And also, if you caught something and it hasn't been mentioned, please, we encourage you to please share so that we continue to enrich in the discussion. So we'll move on to the introduction. The introduction is basically meant to give like a background, then give a rationale for what the study is about, and also now talk about what the study objectives are, and just hint a bit about what the study like approach was. So so at this point, I'll invite you to comment on whether you feel like the research question and the gap were clearly brought out and justified by literature in this section. And yes, and whether even the rationale for the study was brought out well and was relevant. So the floor is open. Please feel free to unmute and also utilize the chat box.
Hello, everyone.
Hello, ma'am.
Regarding the introduction, I see that it was successfully clarified the current state of knowledge, and it did provide the historical and the conceptual context of the study. I think that it also did describe the present and regional, especially context of Africa and East Africa especially. And what I see that the authors did support the statement with the relevant study and statistics. And it's also, I see that the hypothesis, they did brought up the gap, and it was justified with the previous studies. Thank you.
Thank you, Mab. Anyone else would like to add to Mab's comment? Maybe Joy will be reading the chat box meanwhile.
Yes, from Moses, he says, the introduction sets things up well. The gap they identify is straightforward. There's not much published data on EEG patterns and indications in Kenya. What's missing is a stronger argument for why studying peripheral centers specifically matters, as opposed to large tertiary hospitals. They could also say more about what these findings might mean for healthcare planning in similar resource-limited settings. A response from Aditi adequately covers EEG basics, the clinical importance of EEG in epilepsy, and the local burden of epilepsy in Kenya and Africa, presents the research gap well, and the utilization of EEGs and limited local data on patterns of abnormalities, and justifies the study's purpose quite convincingly. Joy Wainaina says the rationale is justified as there is high prevalence of seizures in Kenya, Uganda, Ghana, and Tanzania. The research question has also been answered. And finally, Sumaya says the author has presented the burden of the disease globally in Africa, but not locally. The rationale behind the estimation of prevalence is not stated. The research question is clearly stated and justified by the literature and identifies the need for local data.
Okay, thank you, Joy. Maybe to just respond, I think the purpose of the study was not to build on the local data, because there isn't much, but I believe there are a few studies that have been done locally, but there's also this multi-site study that was cited just to, on the prevalence of epilepsy in different centers. And I think, as someone also brought out, another really important gap that this study also feels is the fact that it's also at a peripheral facility. Most studies tend to be done in the large referral centers, and so you find that maybe there may be underrepresentation in literature of peripheral facilities out there, because not much data is reported from those centers a number of times. So I think that's well brought out, and the feedback is also I think sufficient for us to progress, unless anyone has an additional thoughts on the introduction and maybe what else it could have had. But I think this is also well done, and even as we read, we also learn from it, as we also plan to conduct our research in the future about how to go through the sections of an introduction by starting with the background of what the condition is, looking at the data, and bringing out clearly how there is maybe a gap, and also now bringing out your research question clearly towards the end of the introduction. So I think that's well done. So we'll move on to the methodology. So again, for the methodology, we'll discuss each of the subsections in a methodology, and we'll discuss each one of them and see whether they are appropriate, and whether they also were implemented appropriately, and whether they also answer the research question. So number one is a study design, described, and the study setting. Have they specified the study period, the target population as well? And for sampling, have they described the sampling frame, and is it representative of the target population? And so does it cover this population at risk? And is the sampling method appropriate as well? And is the sample size also appropriate or enough to generalize findings? And if there was a sampling calculation done, is it appropriate? And for the criteria, the selection criteria, both inclusion and exclusion, has it been well defined? Have the eligible patients criteria been well and clearly stipulated? And for those patients who've been excluded as well, is it justified? And for such patients to be excluded? And in terms of the data collection procedures as well as instruments, were they appropriate? Were they standard? And are they able to actually confirm and also report on the condition? And were there any ways to validate this tool and also to avoid any bias? Was it all these things about testing whether a tool is appropriate, measurement tool is appropriate or not? And when it comes to the analysis, comment on whether the software was stated and whether it was well done, and whether the prevalence, because that was the main thing being reported from this study, was reported appropriately, as percentages, with also confidence intervals being calculated, and any other additional analysis or subgroup analysis. Maybe have they mentioned what else they assessed? And importantly, have they mentioned about ethical considerations in terms of seeking institutional approval by an ethics review board, and whether in the data collection procedures, consent and data confidentiality procedures were followed and also, controlled and minimized. So those are a lot of points. And as we mentioned, they are very important, each one of them, when it comes to the methodology section. So here we will take, we'll be willing to take some time. So just comment and let us know how you your thoughts on the methodology. So the floor is open.
Okay, so probably I can try. So far on the methodology, they did state that they're doing a retrospective cross-sectional study. However, once again, they did not state the specific hospitals. If it was an inter-hospital study, they just said it's a study done in Meru. Still under the setting. They also did. It's quite good that they gave us a period for the study, stating it to be between 1st June and 31st December. For the sample frame, they later on in the results section they told us the number of participants. However, they did not give us their sampling method. They also did not tell us whether they were doing it, but they also did not tell us whether they're doing it by just checking hospital records or registries. They, however, mentioned that they are mostly dealing with referrals. They also did not list the inclusion and exclusion criteria. And under the, but they gave us the, later on they mentioned the different criteria for the groups that they were doing their data analysis for, and gave us values. They reported subgroup analysis with age, gender being one of them. And the data collection, they told us they're using questionnaires and the EEG, so that one was well covered. And they also liked how they mentioned, because it was measurable, because they mentioned the 1020 international system, which is standard and replicable. And also the 30 minutes, the minimum of 30 minutes is also applause, an area of applause, because that is adequate for wave, for the wave coverage. And however, also under the data analysis, they did, as it was mentioned earlier, there was a discrepancy with the SPSS tool used. And they also, however, did not mention, although they did it later, what they were going to use it for. So it would have been good if they stated they were using it as they did the chi-square test. It would have been good if they also mentioned it here. And also they should have also given us their confidence interval they were going to use. Under ethical consideration, sadly, I did not find any registration review board number listed, and they also did not mention whether they got ethical approval. Also, they did not hint at whether consent was taken from the patients. And also under ethical review, they did not also highlight whether the ability to withdraw was granted to the patients. And also, they also did not mention what they will do in case of confounders. Yes. Similarly, also, just an addition, they should have mentioned under data analysis whether they should have they did any blending and any techniques they would have used for dealing with confounders. Back to you, Felix.
Well, thank you, Teddy. I think that's excellent, and it's an excellent like through and through appraisal of each section of the methodology. And I think we'd also mentioned last time that I think it really helps if there are subsections in the methodology sometimes rather than continuous prose, because it helps you remember each of these sections and to give as much description as possible. And I think Teddy has brought out a number of areas that are important, as starting with the sampling. I think it's sort of implied. They didn't explicitly say what sampling technique they used, but maybe you can. It's implied that they did consecutive sampling because they said they analyzed all EEG cases from this period to this period. So maybe just all the cases that they had, but it's always important to say that to clarify how if at all, because that's also just an assumption, and it's always important to clarify. And I think when it comes to statistical analysis, that's another important part, because it's very important also to be clear on what parameters were analyzed and how they were analyzed, what tests were done. And as also Teddy has mentioned, confidence intervals are really important when reporting, even because it's a sample, it's not the entire population. As long as you're reporting from a sample, just giving percentages is often not enough because it affects how you can compare that to another population, and they help with deciding on the precision of your estimate. Because the sample is just the percentage is just from the sample, it helps you decide, see how precise it is for when now you bring it to the main population. And I think we'll share more resources on maybe why confidence intervals are important and how to calculate them as further reading materials second after this session. I hope you received the other resources we shared last time from Prevalence studies. So yes, so I think that's well brought out. And ethical considerations was another major omission, as has been mentioned. So that's very well caught. So any additions from the chat box, Joy?
Yes. So most of the responses are more or less what Teddy has said. Read one from Zipporah. She says, the sample frame is not representative of the broader population of all EEG cases done in the region, since it was conducted at a single outpatient physician clinic offering EEG services in Meru. On sampling and sample size, I think the study has utilized a non-probability convenience sampling method because they analyzed medical records of all EEG cases performed in the facility in the stated timeframe. On the inclusion and exclusion criteria, there was no mention if exclusion criteria, there was no mention of exclusion criteria, thereby suggesting the study included every record available at the time period, which means no records were excluded from because of being duplicates or incomplete, hence making the study somewhat unreliable. Yes. One more response from Purity. The sampling method is likely to have bias due to systemic exclusion. There is no inclusion and exclusion criteria, and also paper fails to account for likelihood of duplicated and incomplete records. Yes, I think most responses are just repeating that. So yes, I think we can continue.
Thank you, Joy, and thank you all for your responses. Yes, I think it's always best, I think, if it's mentioned explicitly so that you don't, especially when it comes to the inclusion and exclusion criteria, because that would have helped because it fit all of them. And it would also be good to know if maybe whether this is the only EEG service area in that region, because maybe the sample is probably representative because maybe everyone around goes there, but that's all just assumptions. That's why all this detail ought to be included so that it's also easier to understand the kind of results that will be that are being reported, and their validity and realizability as well. So thank you all for your very helpful insightful feedback on that section. So we'll move on to the results. So here we'd want you to comment on first if participant flow, if at all it was included, and it's particularly for where there's an inclusion and exclusion of a number of patients, and whether also comment on the description of the demographic and clinical characteristics of the sample, the age, the sex, and all that, and now the prevalence with confidence intervals as well, and then comment on the tables and any figures included, any charts, all these charts that have been included as part of the results. Please comment on them, and are they well labeled for the figures and charts? Are they self-explanatory? Do they immediately make sense when you look at them? Are they intuitive by just you understand what the table is representing by just having a look at it? Is it well labeled as well? And does it have all the necessary axes and legends and descriptions of what the figures and tables contain? Yes, and just visually, are they clear, consistent, and accurate in their representation? And are they also neat? Just all that is also important to report in the results, and just anything else that you maybe observed and caught in the results, good and also maybe needing improvement from the results that are here. So the floor is open. Feel free to unmute and comment on the results. Okay. Anyone? You can just also refer to the report you submitted. I'm sure you all had feedback. It's feedback, as was mentioned in the first session, done by Dr. Mwachaka. Appraisal isn't about being negative. It's just about commenting, and yeah, so even saying it's good is feedback.
There are a few responses.
Yeah.
Yes, from Cynthia, she says, the results section provides a clear quantitative summary of the study's findings, supported by tables. The analysis of the 455 EEGs over the 2.5-year period also provides a substantial database for the peripheral center. It has also included key demographics like the male dominance and the concentration of cases between the ages 10 to 19. Wamaida says the pie chart could have been labeled in a better way, so as not to distort the normal outline of the pie chart. Sumeya says prevalence values are reported, whereas confidence intervals are not. Denominators are specified. Subgroups and sensitivity analysis are appropriate. All numbers match across text, tables, and figures.
Thank you. Thank you.
Yeah, I will continue. Aditi says results presented clearly with patient demographics, referral reasons, EEG findings, and statistical associations. There's the prevalence rates and patterns are quantified and stratified by age and gender, statistical significance and modeling results, logistic regression and predictors of abnormalities are appropriately reported. Purity says there's discrepancy in their values. Abnormality site totals and percentages are off. The data in the tables does not match what is in the text. Angela Muriungi says handedness was mentioned as a variable in the materials section, but it is not mentioned in the results. Fatima says again that there was no mention of how missing data was handled. Lorna says there is a slight error in the bar graph. The chart goes from 10 to 19 years to 20 to 19 years. Okay. I continue, Felix. There are quite a bit.
Yes, keep going.
Okay. Okay, Rukia says a study flow diagram clearly showing the number of subjects screened, included, excluded, and those recruited should have been added. Okay. Beryl says the study gives a clear presentation of distribution. However, there is a percentage that differs from the abstract. For example, she gives generalized seizures at 48% and the table is at 42%, creating confusion. Moses says little dense for a fast or cursory read. Again, confidence intervals. The tables are generally well organized and the figures help visualize the data, including two nice examples of actual EEG tracings. The internal consistency is mostly okay. They mention using logistic regression, but don't mention the full results in the table, just a brief narrative description. Wambui says confidence intervals have not been reported. Subgroup and sensitivity analysis are appropriately covered. The inconsistencies in table 2. Those who have the abnormalities at 304, while the numbers in the EEG diagnosis breakdown adds up to 306. In the type of abnormalities, the total number, the number totals to 310. In the abnormalities site, total number comes to 309. Okay, Margaret says the commonest reason for EEG referral according to table 1 were seizures at 56.2% and organicity workouts at 5.9%. However, it is stated that it is seizures and evaluation of treatment response, 8.1%. The pretest diagnosis for epilepsy is stated as 66.5% and 66.6% in the table. The generalized location of the abnormalities is stated to be 47.3% and 33% in the table. So the differences in what is stated and what is presented in the table. Edwin says figure 5 should have been a screenshot of EEG to avoid the reflection of the researcher and better quality. Fatima says, are these discrepancies caused by author overview or system errors like SPSS? And finally, Margaret says, the authors have used tables, figures, a pie chart, and bar graph. One of the categories is other, which is ambiguous. Specifics or examples of what comprises of other should be captured. In figure 1, there's a bar for unknown. The study should describe how the missing data was handled and give reasons for it being missing. Yes, that's it, Felix.
Oh, wow. Thank you, Joy. That's quite comprehensive. I also noticed a few inconsistencies. Others I actually hadn't seen at all, and that's really good. I think it's even as I guess you conduct your own projects, these inconsistencies, it's quite easy for you to make such errors, especially if you're very keen as you prepare your manuscript, because a lot of times people analyze the data and then they analyze it again and as they prepare, and so you'll find maybe you wrote this section and then went reanalyzed your data, came back, wrote again, and then you didn't realize you've put different results. And because once you have these inconsistencies, they really do affect the credibility of the results, because it's a bit confusing. And I think you've done a great job in pointing out all these areas. And yeah, I don't think there's much to add. Just the only thing would be, just an addition would be, I think there's some of the tests and analysis that have been reported, such as logistic regression and all, but they weren't necessarily included as part of the tests that were intended to be done in the methodology. So the results should always be reporting what said would be is being done in the methodology, such that there is no new thing that wasn't initially part of the parameters being reported in the results. Unless it was just maybe an incidental finding, but some analysis and all should always be mentioned there. So I think that's well done. And we'll move on to the second last section, which is the discussion, where we'll just invite maybe one or two of you to just comment on the discussion and evaluate, whether the flow of the discussion is logical. Have they stated the principal findings and then gone deeper to synthesize and interpret these findings, using evidence, and that evidence is citing literature and not over-exaggerating their results, but also acknowledging potential biases and limitations that they had in their methods. While also just doing all these the different comparisons to similar studies and all these things that go into a discussion, and whether the whole discussion ultimately is logical and also adds value to science. So the floor is open. Please feel free to unmute and comment on the discussion. Luby, and go.
Hello,
Okay,
before you continue.
Okay.
Oh yeah, sure, Arnold.
Sorry, I had my hand raised for like 10 minutes. I don't know how it wasn't seen.
Oh,
But
sorry, sir.
you see, in the results section, there's like all of these percentages, majority of them I think have an issue. Because if you read just before, like where the results begin, if you could scroll up. Okay, it's a bit higher, yeah. So you see, it says a total of 445 patients underwent EEG during the study period. Then if you go a bit lower, just go down, further down, just keep going down. Yeah, then you see that it reads, of all cases, 304 displayed abnormalities on EEG, with 42.7 and 19.3 exhibiting generalized and focal seizures, respectively. So when I read that statement, what I understand is 304 people had errors, abnormalities rather, and out of those 304, 42.7 and 19.3 were the ones with generalized and focal seizures. But if you go to the table and you do the calculations, it's not like that, because you'd find that on that, not table 2, sorry. Yeah. You see, when you go to the type of abnormalities, if you calculate this normal, that 139, it does add up to 31.2%. But then if you calculate for generalized epilepsy, you'll find that 190 has been divided by 445 and not by 304. So it's like saying, out of the people who had errors in their diagnosis, then you divide that percentage by everyone rather than the ones who had errors. I don't know if that makes sense.
Yeah, I think that makes sense. I think
Yeah, so the calculation is wrong.
Yeah. Oh, yeah, that's
Because
really
ideally they should have done 190 divided by 304, which is to mean that out of the abnormalities, that percentage, which should be 62.5, are the ones who had generalized epilepsy, not how it has been displayed. So that calculation is wrong.
Okay.
And then apart from that, there was a few other problems there. I think this one was mentioned, but the table 1, there's a place where they had mentioned that the clinical diagnosis was encephalopathy, epilepsy, and psychosis. But when you go to table 1, they have listed seizures rather than epilepsy. That's another error I noticed. And then also the addition, I think someone also mentioned this, that if you add the abnormality site, you're going to get a total of 445. Which, I mean, you're going to get a total of 449, not 445. And then also the percentages. Some of these percentages, if you add them, they add up to 99.9. Others are 100.1. Like, there's like a lot of tabulating errors in the whole of table 2.
Okay. Thank you, Arnold. I think maybe the results will maybe need a relook, because sometimes maybe it's us or maybe also misunderstanding. Because again, because if you represent, as you mentioned, even for the last discussion that we had, I think there were some tables that were really, really confusing. And sometimes it's because of how the table is represented that maybe we could misunderstand what it's all about. But I think that is very, very important too, because it also somewhat will distort the results and percentages. Because for some of the findings that have been given here, they're the main findings of the study. So I think it will be a bit concerning if they are inaccurate, if they've been calculated inaccurately. So yeah, I think that will be so a big an area of concern, and maybe an area we could follow up on. So thank you for that, Arnold. So yes, thank you for such a thorough appraisal of the results. So I think we'll move to the discussion. So maybe anyone who had the discussion.
Yeah, I had like unmuted myself before Arnold, and yeah, that was so great, Arnold. I feel like I learned so much. Yeah, you're so thorough. That's amazing. So about the discussion, the interpretation was evidence-based because the discussion begins by stating that the main finding is that the majority of the referred patients were male, and it also links it to a study conducted in the informal settlements of Nairobi, where a similar finding was found. And it also connects the high percentage of patients under 20 years old to the population demographics associated with epilepsy and other events like that in the country. And I think that the study avoids overstating the EEG's diagnostic power by recommending prolonged EEG monitoring and video EEG that is usually needed for further diagnosis. And most importantly, the study states that absence of EEG abnormalities don't rule out seizure activity. And that, of course, demonstrates that the interpretation is not overstated. Now onto the biases and limitations. The study acknowledges the high rates of generalized seizures and notes that this finding is typical of hospital-based studies as opposed to community-based studies, where the complex partial seizures are more prevalent. And so I think this is an implicit recognition of selection bias in that sample frame. And the authors, they also discuss the limitations of the EEG method itself, and they say that the yield is not sensitive and more monitoring is needed for better diagnosis. However, I found that the authors don't explicitly discuss the selection bias that results from using a single outpatient clinic list as the sample frame. And I don't think, and I think a lot of people have mentioned this, that the 68.3 abnormality rate is not truly representative of all the people with potential EEG abnormalities. And of course, there's a systematic exclusion of people who don't seek out care or seek other care. One of the strongest points in the discussion was the local implications for practice and policy. I found that the study clearly highlighted the implications for clinical practice. There's a recommendation that was made that clinicians should conduct a thorough review of patient medical history because they found an association between clinical diagnosis and EEG diagnosis to be statistically insignificant. And of course, we know that this study is one of the few in the region that outlines the utility of EEG and referral patterns. So yeah, so I think the discussion was pretty good though, in general.
Thank you so much, Nsolubi, for the comprehensive feedback on the discussion. Does anyone have any additional feedback on the discussion? And also, Joy, you could check the chat box. Anyone has also added a few comments on the discussion?
Just one addition. Okay.
Maybe Teddy had unmuted first, and then Sotia will go next. So Teddy, you can go first.
Okay, so just one addition. Both discussion and the results, I think they should have used patients already on anticonvulsants as a confounder because anticonvulsants usually affect EEG readings. So it might have affected some of their results. Back to you, Felix.
Yeah, thank you. And what was the I think they given the proportion of patients on anticonvulsants, which was quite high. I think also combining it will, I think combining the two and reporting may affect. It's a big confounder, I believe. So, and as someone had mentioned, unknown, sometimes I think you can opt to drop the unknown because you're not sure and maybe may affect the interpretation. Just someone would ask on how missing data was handled. So I think, yeah, I get what you're saying. Thank you for your feedback. Sotia? Oh, Soita, sorry,
Soita. I'll start with the results. I have something for 2 decimal points because they express they're a bit more accurate than being one percentage that expressed 1 decimal point. Also, I noticed some inconsistencies because you're told that 141 patients had no notable EEG abnormalities, but 139 had a normal EEG diagnosis. So these 2 patients, we are not told if maybe they had no EEG abnormalities. Okay, they had no EEG abnormalities, but we're not told if maybe it was a misdiagnosis or not. Also, the sample size under the type of abnormalities, like you said, it exceeds the actual sample size by 4, and there is no mention if one patient presented with more than one type of EEG, more than one type of abnormality. And also, 139 patients, that's 31.24%, but under the abnormality site, under the null category, you have 139 patients, but with 31.7, which is an error there. Then figure 3, it notes 31.2% of subjects as normal EEG diagnosis. So if we were to go with that, then the discussion, then that 68.3 will actually be wrong, and instead would have been 68.7. Yeah, apart from that, the presentation was good.
Thank you. Thank you so much, Darwin. That's very thorough. I think for you to have discovered that, you must have been very keen and taken your time to also review that. So I think well done. And I think maybe the biggest concern has been the inconsistencies in the figures, and because they are the statistics, but it's always very, very important because you can do a very good study, but ultimately be let down by the statistical analysis and approach and the representation of the results, which may affect the whole generalizability and also validity of the study. So thank you so much. So we'll come to the last section, which is the conclusions. We invite you to just comment on I'll combine conclusion and references so that we just comment at once, so that we invite our guest editor to give comments, and then we'll come to the end of our session. So, was the conclusion a concise summary of the prevalence findings and its implication, in this case for clinical neurology and seizure management of seizure and maybe reporting of seizure disorders in our place? Does it importantly, it should not be introducing new results? The conclusion is not where you should be introducing new findings or new data that hasn't been discussed before. And also, does it give recommendations, but in a brief way for future research? Yeah. So, and for the references, were there any concerns that you found with the quality of the references, and also maybe if anyone went to the extent of trying the accuracy of each of these references? So yeah, you can comment, and whether they also follow the journal's referencing standards. So yeah, the stage is open. You can comment.
I just wanted to comment on the references, not the conclusion.
Yes, sure.
They were generally good, like they were current and all of that, and they were present and balanced. They had the minimum number of references as well, but that WHO thing that was mentioned, I actually I like highlighted the link, and it took me to something about I guess abortion. I don't know if that has to do with epilepsy, but it wasn't. That's what I got when I actually like went to the link. I did try for some of the others and they were accurate, but that was just a big red flag for me for the references, but otherwise they were okay.
Thank you, Clarence, and good job for counter checking and confirming the references. It's important to do that. Thank you. Any other thoughts? Maybe as we come to the end. Maybe the last question. Sorry, Arnold.
Okay. So for the references, first, I think the number is a bit low because, yeah, I think those were 18 papers. I think that was rather low. And then to add on to that, the papers, most of them, okay, 8 out of the 18, which is like 44%, which is almost half of them, are older than 10 years, like they were written before 2015. So I think just more, recent papers would have made the paper a bit stronger. And then also for the conclusion and supplemental material, it was like it accurately reflects the findings of the study in the EEG, being useful in confirming epilepsy. But given the problem with the results, I think now that's what would bring the conclusion down, because the basis of the conclusion being the results which are off make it like unreliable.
Okay. Thank you, Arnold. Thank you for the feedback. Joy, any comments on the chat box?
Excuse me.
Yeah, Pampalili, you can go ahead.
So I'd like to comment on the conclusion. So if you forgot the results and the discrepancies, I think the conclusion was actually well done. The recommendations given were quite good. For example, that part, it says that EEG should not be regarded as the definitive investigation for seizure disorders, but as an extension of clinical assessment, and the rest of the other recommendations. I think the recommendations are well done. And also the implications for neurosurgery, that's all actually.
Thank you. So thanks a lot, and thank you all for your contributions, for an excellent job, and for also submitting your reports, and also just for the lively discussion. It's been very insightful. I think everyone participating is also learning. I'm also learning so much from the discussions that we've been having, and I'm sure everyone is also gaining a lot. So I think at this point I will hand the session back to Joy, who will introduce our guest editor, and then after that, I'll just give a brief, maybe a report on how the reports have been, and some of the considerations that we'll make. A number of you have sent emails, quite a number, to just with a few issues, and then we'll inform you of the next session. So, Joy, back to you.
So maybe to close.
Caleb, keep it brief, kindly.
Okay, yeah, I'll keep it brief. So maybe something to note is the brand names of the machines used, EEG machines, because they are different. So maybe the author should have said which machines were used. And something else, Teddy made a really good analysis of the method section, but somewhere we went off was, he said about asking for consent from the patients, and yet this is a retrospective study, so maybe the author should have sought for waiver, and then clarified that he sought for ethical approval and a waiver. Thank you.
Thank you, Caleb. Thank you for the additions. So thank you. I think at this point we will close the appraisal session, and I'll welcome Joy back to the stage for the last part of the session. So Joy, back to you.
Thank you so much, Felix, and everyone for your contributions and insights. I believe we've all picked something new. So let me just move on to welcoming our guest editor, Dr. Sood, to share his views. Welcome, Dr. Sood.
Thank you very much, Joy. Thank you very much, Felix, and all the participants. As this session was going on, I can tell you I was just smiling because I was really enjoying the discussions in the background. And I think guys have really done well to dissect this. I mean, I was just listening to the conversation and just laughing and saying, you are just brilliant what you have done. To tell you the truth, I think as you continue with these sessions, you'll actually be much stronger. I can see how your thoughts are from the way you started from the initial identification of topic. And I really enjoyed the fact that you also appreciate that there are things which are really good and there are things which needed to be amended. And the good catch is whenever you have statistics, that's where you start having blunders and you caught up everything, because I had gone through this paper almost 2 weeks ago. And I actually, when I was listening, I was referring to my notes on what I was also analyzing. And I can tell you, you almost scored everything in those notes. I can tell you that. So if I was near, I would have invited you for Uji also, so that you can celebrate with me. But you can pat yourself at the back, and this has been very, very excellent discussions. And I hope you continue with this. And what I liked about the discussions is, please don't feel shy. Don't feel shy. The more you discuss these topics, there's no right or wrong. It's only we are sharing ideas. Others have got a hawk eye. They can see things which others would miss. But I really enjoyed it so much. Trust me, even if you wanted to continue discussing, I would still listen, because I was just smiling and feeling so happy about this. So thank you very much once again, all of you. Joy, thank you very much. Felix, thank you very much also. So I will end there. Thank you.
Thank you so much, Dr. Sud. It's been a pleasure to also have you, and to also for joining us in this session. And so for your reports, please make sure you submit them. So we've been sharing them with their journals, with the different journals. So, and the editors will reach out to some of you to, be part of their journals, as reviewers and part of their ecosystem and some of the things that they're involved with, just to also strengthen, as we mentioned, part of the objectives of these sessions was to continue strengthening our local journals, just to ensure that we have that rigor being implemented in the, in all steps of scientific literature in our journals. So again, this has been a wonderful session. Thank you all for joining. Thank you for submitting your reports. Quite a few have reached out requesting for an extension, which we've granted. So please go ahead and submit your report for those who haven't. We will keep the forms open. Even the first session form is still open. And there was also a question on whether we'll be marking and giving the reports back on the feed. So I think we thought we would initially, but the submissions, like for the first session, there are quite many, like 200, and we realized that's quite not even feasible. So we'll just allow you to appraise yourselves as you go on. So just attend the sessions, figure out what things you missed, because it's just a journey of self-improvement. But the important thing is that by the end of these sessions, after the end of the 6-month bootcamp, we'd expect that you'd have submitted reports for every single session for you to qualify for the certificate at the end. So otherwise, it's been great. We'll share the paper for the next session. We're going to look at a different study. We're going to look at a case control study from JOKAP, the Journal of Obstetrics and Gynecology of East and Central Africa. And we'll just do it the same way once again. So thank you so much for joining. Please follow all our journals on social media. Especially also for us as EAJNS, we are working on a few things. For those who follow us, you may have seen that we're about to start a podcast just to also promote our authors, so that you also get to interact with literature in a different way. So please just keep following us and engaging with the different journals. I think that brings the session for today to an end. So we thank you all for joining, and have a good evening. So thank you all. You're free to leave.
Thank you, everyone.
Thank you.